I'm Bob Steensen from Columbus, Ohio. We wanted to share with you some instruments we use for kinematic alignment. We feel kinematic alignment is growing in popularity. It tries to match the native joint surfaces so the ligaments are balanced normally, and we feel that this is an up-and-coming way to do total knees, and there's a simplicity to it, not only the philosophy, but we believe the instruments offer some simplicity as well. So we're going to demonstrate this with a medial pivot knee. We thank Microport for providing the saw bones for this demonstration. Medial pivot knee is stable medially, but is able to rotate laterally. So it's one of the most stable primary knees, and that's a benefit. And if we're trying to maintain medial pivot, we're also, with kinematic alignment, trying to match the native flexion extension axis as well. So you try to match the medial rotation axis and the flexion extension axis, and we believe patients will feel this as a more natural knee because we're matching the two axes of rotation of the knee. So for the instruments that we've developed for this, first thing you want to know is how can we get the joint line back where the joint line was? Well, you have to have some determination of cartilage thickness, how much cartilage wear was there. And you can assume that it's 2 millimeters, but that's an assumption, and we have a cartilage thickness gauge that can be used. So here, if you press this, the plunger will go down and the tines will go into the cartilage. You can measure, and it's 2 millimeters of cartilage there. So if the other side was on bone, you would extrapolate that that was 2 millimeters of wear. On this model, you can press, and this is 1 millimeter of wear, so you can make appropriate adjustments. So we have a cartilage thickness gauge. Now, what can you do with that information? To simulate a typical case, and this was 2 millimeters of wear. So now we're going to place our intramedullary rod. And then this is the femoral guide, and it's a little different than you're used to because its angle is not fixed, it's variable angle, and that there are two pads on the distal surface that can dial out. So in this particular case, since we're assigning 2 millimeters of wear to this femur, we've dialed this out 2 millimeters because the implant's 10 thick. So the 10 is our default cut, but we don't want to cut 10 where it's already worn 2 millimeters, so we want to cut 8. So here you can turn the knob and dial out 2 millimeters, and then no millimeters on the other side because we do want 10 there. And then we're going to slide this on the rod, and then we'll see what angle it is. In this particular case, it's a 5-degree angle. So then you pin this, and you unhook the guide, and then you're ready to cut. So now, once we made our cut, we can take off the femoral guide, and we're going to verify the thickness of our cuts. I typically take the saw blade and put it on the back because there's a thickness to the saw blade of bone that was removed. So for the unaffected condyle, we were hoping for 10, and you can see we've got a 10 millimeter resection on the lateral side. And on the worn side, the medial side, we were hoping for an 8 millimeter resection, and we have 8 millimeter resection. Now there's a little bit of play in the guide, so if we were a millimeter short, we can usually pass the saw through the guide one more time and shave a millimeter. If we were 2 millimeters short, we simply move the guide to 2 millimeters by changing pinholes. If we were 1 millimeter over, then we'll show you later in the case how we can adjust for that. So next, we have to fit our AP position and sizing and rotation. So this is a posterior referencing sizer. So we're going to place this behind the posterior condyles. And we usually, for kinematic alignment, usually set it at 0, but because the 3 degrees of external rotation doesn't need to be, because we're leaving our tibia where it was. but you can adjust if you wish, because this does have that availability. So then we pin that, and that is set our AP position. Again, we're posterior referencing. We've set it at 0 degrees of external rotation, and then we'll do our sizing. And in this case, it's going to be a size 5 femur. So again, we've set our rotation at 0 because we're leaving the tibia in a natural position. Most mechanical alignment, you take the 3 degrees off of the tibia, so you have to externally rotate to get a reasonable flexion gap. So now we've determined this is a size 5, so we'll place this on the femur. And then we use the screwdriver to make sure that the mechanism is engaged. It can make it go up or down. We usually keep it at 0. If we had over resected by 1 millimeter, we would slide the block anterior 1 millimeter to keep our flexion extension axis the same, but that very rarely happens, so we usually leave this at a 0. And then we use the angel wing to determine if this is a good anterior cut. That's important for sizing. For the posterior cut, we're going to check posteriorly. This mechanism has size 5 through 8 is an 11 millimeter resection, size 1 through 4 is a 10 millimeter resection. We're going to slide this into the posterior cutting slot, and it should be just under the posterior condyle on both sides, because we're unless there's wear, which we would account for, but in most cases there's not that much wear posteriorly. So you've checked it, because this is the important part for kinematic alignment, is having the posterior condylar line matched by your implant. So then you would make your cuts. I'd cut anterior first to make sure that it's the size that we like, because it's not too late to downsize if we wish. We've made our cuts, so we can remove the block, and we think the cuts look very appropriate. So now we're going to take the trial, and you may say, is this going to fit? Well, if you've resected back to the normal surfaces, this should fit. It fits almost all the time. So this fits, and this has reestablished the distal joint line where that was originally before wear, and the posterior joint line. So now the next thing we want to do is determine how are we going to cut our tibia. Well, in this case, we have the knee in extension. We use these gap gauges. That's 1 millimeter through 5 millimeters. And in this case, this was a varus knee with medial wear. So with the knee in extension, you can put the gap gauge and see what the gap is before you cut the tibia. We're trying to balance the knee now, rather than make a tibial cut and balance afterwards by a recut or by ligament releases. We're balancing the knee now. So in this case, we're saying this is a 2 millimeter, or sometimes it's 3 millimeter, are the most common wear on the medial side for a varus knee. So that's going to help us determine the cut we make. So sometimes you can do both sides if there's wear on both sides. Most times there's just wear on one side, so you do one side and have a gap gauge or a spoon just on one side. So now that we've determined 2 millimeters of wear medially, we're going to look at our dual stylus, and we can measure the gap here. We press the button, we slide it up, and it's 1 through 5. We'll go at just under the 2. So if we do 2 for the gap, then if we look at tibial resection, that's going to be 8. So this is based on a 10 thick implant. So on the lateral side, we didn't think there was wear, there wasn't a gap, so we're going to set that at a 0 gap. 0 gap. And that would correspond to a 10 millimeter resection. So 8 resection medial, 10 resection lateral because of a 2 millimeter medial gap, 0 millimeter lateral gap. So the stylus is set. We put our tibial cutting guide on with the ankle clamp, and then we have an added strap for stability. You adjust the ankle to correspond so the rod is matching the tibial crest. You put your stylus in place, then you slide it up and let these settle onto the plateau, and you free the angle so that it can go to whichever angle it seems to settle and seat. In this case, it's about a 2 degree of varus. So we're resecting 8 on this side, 10 on this side. This is at 2 degrees of varus. So if we're happy with that, we can pin that. And then the stylus, the dual stylus, you lock these, you lock this, the dual stylus pops off, and then you can make your cut. This is a flat cutting block, but there's a slotted cutting block too that just pops right in if you wish it. Or if you need to resect 2 millimeters more, you pop this off and you can resect 2 millimeters more. So then you make your resection. So when you make a kinematic resection, it's going to be more even. So it'll look more even, medial and lateral. A mechanical one, this is actually from the left knee, takes much less medial and more of an amount on the lateral side. So a kinematic resection looks more even than a mechanical alignment resection. So once you've made your cut, I don't necessarily measure the cuts because I'm going to actually measure them using the trials. So once the trial is in place, the femur goes back on, and then we stick in our trial. And in almost all cases, it's been balanced and we don't have to recut. So that's the simplicity of the concept, and that's the simplicity of the instruments, to just resect enough to put the surfaces back where they were. We reestablish the femoral surface so that we reestablish the flexion and extension axis of the knee, and then we use the ligaments to help balance, and they tell us how much to cut on the tibia, and usually the angles are very acceptable, like a 2 degree or 1 degree or 3 degree, but you have the ability to override that with these instruments. You have the femoral angle, you have the tibial angle, you have the resection, medial femoral condyle, lateral femoral condyle, medial tibial plateau, and lateral tibial plateau.